have a great, he's an entrepreneur, and he's a businessman, and that's a rare combination. Tonight we have Dr. Miguel Fana, who's going to talk to us about Obamacare. The way this format's going to go is this. We're going to permit several questions from the floor. This is a respected man. All questions will be respectable. You understand that. Also going through on the questions, I understand Obamacare is a contentious issue. All questions have to end with a question mark. In other words, I'm not soliciting speeches from the floor. Our Sergeant of Arms has instructions to carry that out. I know this isn't going to be a problem, but these are the ground rules. Second thing is, any questions longer than 15 seconds will be considered a speech. And remember, we're taking questions. I don't know how much time we're going to have, so maybe a few questions, or it depends what the good doctor wants. You might ask for more questions. We'll see. In any event, to introduce our speaker, I'd like to introduce our treasurer, Chet Renfro. You all know. Chet, come on up.
Really my pleasure to introduce Dr. Fana tonight. Like I said, he's going to speak on Obamacare. He's going to talk about the good, if there is any, and the bad. He's a fine medical doctor in our area. He has 4 offices, both in Pasco and Pinellas County. And he's an excellent medical doctor because he's mine. Look what a specimen. So anyhow, for all of you guys, some of you know Dr. Fana, most of you do in fact. And the ones that don't, he's the guy that put R in Republican. And again, it's my pleasure to introduce Dr. Fana.
Great, what a pickle on there. I don't know about respectable. My wife would beg to differ on that one, if you saw her in action. But, you know, I've researched a lot of the aspects of the law. There's a lot of stuff in there. I don't really like getting into technicalities, and I don't like getting into legal jargon. So what I did was, you know, I looked at most of the things that are important for me as a practicing physician and that I think would be important for my patients. I don't have a pediatric population, I have a geriatric population. So there's some stuff on pediatrics that I'll probably mention briefly. And there's a lot of other legalities that are probably better for people that are, you know, actuarials and people that run insurance plans and all that. So I'll try and keep it down to what my interpretation is of when they say something in the Patient Protection and Affordable Care Act, which is really what it is. That's basically what the PPACA or, you know, PPACA stands for. But if there is anything in particular, we can start with 1 or 2 questions, then I can talk a little, and then we can go back and do a couple of questions. So, you know, I'm pretty open. Does anybody want to ask anything, or you want me to start, ma'am?
I have a question. A friend of mine was recently told by her physician that once you reach the age of 76, you'll no longer be eligible for cancer treatment.
No, you know, oh, okay. If when you reach 76, the question is that a friend of yours was told that if he reached 76, he was not going to be eligible for treatment for cancer. Let me tell you where some of that misconception comes from. There's an issue with that, but here's the problem. A lot of the studies that are out there are usually done up until 75. Nobody really likes to do research past 75. That's changing slowly because our population is living longer. But you know, the risk of complications is much higher after that age. That's why a lot of places are hesitant, for example, to do bypass surgery on people that are 75 and over. You know, in New York, where I trained, they were very, you know, skittish about that. Here in Florida, our population is much older, so we do it all the time. No, absolutely. I mean, it is what it is, or else the surgeons wouldn't be doing many bypass surgeries here in Florida. But that is the reason why, you know, and then when you look at it, right now, the government is, when it comes to Medicare Advantage plans, they started to say, we're going to decrease the funding for Medicare Advantage plans as of 2010, and then in 2011, they were going to lock that in, and they were going to drop it successively until 2014, and they were going to lock it in. Well, the drop is going to be about $1,800 a year, which is about $140 a month. Well, what happens when the Medicare Advantage plan, be it with whoever you have it, you know, all of a sudden has $100+ left? They're going to charge that to you, so you'll have less benefits. So before, if you had to pay $25 for the specialist, now you have to pay $35. If you had to pay $50 for a CAT scan, now you're going to have to pay $75, and so on. If you were going to go to a rehab facility after a hip or after a stroke, and you were paying after the 11th day, now you pay after the 7th day, or you pay $100 instead of, you get my point. Well, on the reverse side of that was they have this new system called STARS, where plans get reimbursed based on the quality care that they provide. And because there really are no quality studies past 75, the plans don't get paid if they do a procedure on somebody over 75. For example, we have to have about 67% of our patients get a screening colonoscopy or the stool card for colon cancer prevention. If the patients get a colonoscopy and it's screening, meaning that there was nothing abnormal, they have zero copay, which is another part of the law. But they don't incentivize you if you do it on people over 75. So some physicians may not do it after 75 because it's more work for them and it doesn't provide an incentive. So they will hone in on people under 75. That is where the 76 comes from. Now, with that said, you don't know if down the road they will say, well, there are really not enough studies to say that this is beneficial after 75, therefore we're only going to cover services for things that we know. So we don't know. I mean, they may or they may not. The problem is that right now you're just, you're waiting for the government to make the decision, and the government will make the decision based on cost. So if all of a sudden healthcare expenditures continue to go up as high as they are, and more people are in the government, then they are going to ration healthcare. There's just two ways to lower cost, and one of them is to pay less for the services, and the other one is to pay less, to pay less the doctors and to cover less care. That's the only two ways, and you can't do it with one way alone. You have to, do a little bit of both. So that's going to be a very tough decision. And that's where the 75 comes from. But here's what's going to happen for sure. Your co-pays and your deductibles for chemotherapy are going to be higher than what they are now. And if you are on some other plan that is some sort of retirement plan, from your employer, as a lot of people know, those plans are asking you to pay more now, and some people are just opting out. So you will have, they won't deny it, but you will have to pay more for it. And a lot of people just, they won't get it done. So that is where it comes from. They won't deny that. They'll make us pay more for it.
Thank you, Doctor. First off, thank you for taking the time to read the act. If Washington had done that.
Well, I didn't read the whole thing, trust me. I have to work.
Like it or not, it's here and we have to deal with it. So from
Correct.
a fiscal reality perspective, the average cost of walking into a non-insured to walk into an emergency room runs about, their bill starts at about $1,000 right then, just for walking in the door. Conversely, for a walk-in clinic, it starts at about $200, $250 to walk in there. If you've read it.
Unfortunately, not enough people, even people with insurance, go to walk-in clinics, and they are a better user of non-emergent care or non-urgent emergent care. So the problem is that sometimes you can't blame the patient because the patient doesn't know what to go to the ER versus the walk-in clinic. Ideally, everybody should just go to a primary care physician. There is just no better way than that. And if the primary care physician's office is closed from 5 on, then they should go somewhere else.
I have a question. Today in the paper, it said that California did not have enough doctors to handle the volume.
Great question.
Okay.
Absolutely. You know, that's an excellent point. He said that California announced that they do not have enough doctors, or they will not have enough doctors. And her question was, where do I see that headed? Well, there's a lot of problems with that. The first issue is, theoretically, they said that with the new healthcare law, 50 million people were now going to be covered that they were not. And that is about 20% more of the people that we currently have covered. 20% more. That means that the average doctor's panel is going to go up by about 20%. Well, for those of you that go to the doctor routinely now, you know, we're spending 15, 16 minutes with people because of the way, you know, we get reimbursed and because of the quality services that we show that we do. But the average fee-for-service physician, which is 80% of the doctors out there, spend about 11 minutes. So you have to expect that to drop by about, you know, I would say 12%. So now you have somebody that has a lot of health issues that will only be able to spend 8 or 9 minutes with their doctor. So here's the issue. We have about 800,000 doctors in the country, right? Probably 20% of those are primary care, meaning internal medicine, family practice, pediatricians. So at the end of the day, pediatricians see kids. Most of the people that go for routine care and for complicated medical care are people over 65. That's internal medicine doctors and family practice physicians. So here's the issue. You have to see more patients now. There's nothing in this law that talks about tort reform or controlling the cost of malpractice premiums and, you know, decreasing the risk of the doctors for getting sued. So now you have less time, which means that you are probably more likely to miss some things. Third, how many people do we have right now going into medical schools? We have about 18,000 graduates a year. So the net is probably less than that because of some doctors that retire. So you're looking at maybe 12,000. Well, that's going to get worse because I hear now a lot of my colleagues discouraging their kids and neighbors' kids and everybody going into medical school because of this current climate. So what you will see is you will see a drop in that. And that has not increased, by the way. I'm talking about probably 7 or 8 years of data. About 2 years after I came out of training in New York, 1999, that has stayed steady between 16 to 20,000 doctors for primary care a year. So there will be a shortage of doctors. It is going to put the sickest people at risk because they're going to have less time to see them. There are going to be more lawsuits because of that. And because of that, you're going to discourage people that are going into medical school now. So in addition to that, the reimbursement for doctors is going to drop because how are you going to cover more people without adding any more dollars? So the reimbursement is going to drop. So you still have to see more people so that you can make the same amount of money. And at the same time that your reimbursement, the money you get from the insurance company drops, you can't drop the salary on your staff because inflation goes up 4 to 5% a year and your malpractice insurance continues to go up. The more you practice in medicine, because obviously the more you've been practicing, the more likely you're going to get sued. So it's a big issue, the number of physicians. We are doing total opposite. For an aging population, instead of incentivizing and increasing the number of physicians, we're actually going the other way. And of course, what's going to happen is medical schools are going to lower the bar. So now you will have people that are less qualified going to medical school, and they will be accepted into medical school, which results in, you know, people that normally wouldn't get it. And I don't mean this in a bad way, but, you know, I would really want somebody very good to be my doctor, and I wouldn't want somebody lackadaisical. So that really is the issue. You're going to get people going into medical school that are not, you know, the people that are in there now. It is what it is. So, but that is a great question.
Yes, sir. The McAuliffe Foundation a few years ago made a study on computerized records saying it would save tens of billions of dollars to do so. Speaking to doctors, it turned out that's not true.
Total opposite.
Total opposite. You're seeing fewer patients and it's costing billions of dollars. And the McAuliffe Foundation just admitted that about two weeks ago. I was just going to ask, are you finding out in your practice that computerized records are taking longer and not working?
Absolutely, yeah, because now the number of visits has been reduced, because as you know, before, we would just make some notes and move on, and when you know the patient very well. But now the electronic medical record, sometimes the computer, the internet is down, or it's slow. A lot of doctors are not very savvy with a keyboard, unfortunately, so they have to go and buy dictation software, which is expensive. In addition to that, our office, we have 2 offices in Pasco, 2 in Pinellas County. We hired 3 full-time IT folks, whereas before we would have just had 3 medical records clerks. IT people charge more money. They charge more money than the people that we used to use for medical records. Now, I can tell you this, there is a benefit to the electronic medical record. We make less errors with medication, and we can provide, certain services. There are, like when somebody has a CAT scan or something, I can find that easier. But my day-to-day visit with patients has increased by about 3 minutes. And that is the problem with the electronic medical records. Once you see somebody for about a year, you know them in and out. But with the electronic medical records, every note is a separate standalone note that you have to write a lot of things into. And IT people are more expensive. They used to say, oh, forget about that. You won't need a medical records clerk. No, we don't. But we have hired a full-time person for scanning. All the stuff that we used to sign before, and all the letters for patients, and family medical leave act, and all that stuff that comes in, the physical therapy plan and all that. Yeah, we have to print that, and it requires our signature. Well, guess what? The receptionist printed, and now we have a full-time scanning person in each county. So we would have just been better off, without having to hire 3 IT people. So it is much more expensive than before.
Question.
Sure.
What is your feeling about nurse practitioners filling in for what the doctor or doctor the areas they can cover?
So the question is, what do I think about nurse practitioners? Okay. Say that again? No, I don't think he's putting me on a spot at all. I think nurse practitioners are excellent. And I think that if you have a nurse practitioner with experience that works with a physician, I think nurse practitioners provide excellent care. Do I think a nurse practitioner should practice standalone? I don't think so. Because, there are a lot of things, especially as you get older, that nurse practitioners really need to, think and talk about it with the doctors and sort of reach a consensus. We have nurse practitioners in our office in St. Petersburg, and we're currently looking for a couple, so we love them. And they're great. They were nurses before. They spend more time with the patients than we do.
This is what I'm trying to bring out. A lot of people are not familiar with it. I'm very familiar with it, with Alaska, Canada, the United States. I have families involved in this. They've been working with this for a long time. The nurse practitioners today, and people don't realize this, they are as good and skilled as the old country doctors. They are permitted to do surgery, to dispense drugs, and Florida, they don't have that ability. In Alaska, Canada, they do.
Is that a question or a speech?
Wow,
That sounded a lot like a speech.
they're tough over here.
Let's go.
Hey, Gail.
Back to the medical records, what is the timeline for the doctor's offices to put in electronic medical records?
Well-
I went to my doctor, and then I went to another doctor today, and neither one of them are doing that. So is there a timeline?
The key is there a limit as to when doctors should all have electronic medical records and be paperless? And I think the limit is end of 2014. But let me tell you this: I have a lot of friends that have retired because they don't want to do that, and they were not allowed to be grandfathered in. And doctors retire later, 65, some of them 70, others, But I know people that are 62 and retired because they don't, and they look fine. They could keep working. Some of them actually, are taking teaching jobs. Others are just working in the hospitals as reviewers of charts and stuff. Yeah, so it's, think about it. If you've been practicing medicine 30 years when there was paper only, they don't really want to do this. I don't blame them though.
I have a question. How do you think that this is going to affect an entrepreneur or the business owner that has either 50 or less, I think that it's 50 or less employees, and what the difference is in those two entrepreneurs?
That's a good question. Let me see. I have that here because somebody asked me the other day, and I don't want to say this any different. I like to generalize. I think it's a Dominican thing I got from my parents, but let me tell you, as far as the small business health tax credit, there was supposed to be a tax credit for small employers that gave health insurance to their workers. And
What's the number?
well, there's different levels. So if you have 10 employees, then the credit phased out at an average of about $50,000 over 4 years. If you have 15, that was only $41,000. If you have 20, that was only $32,000. If you have 25, that was only $25,000. But the problem with that is that there were about 4 million people or so that could benefit from that. And obviously what's happened is that only 228,000 have claimed the credit. So not as many people have claimed the credit. They've just rather opted out and not offer insurance to people that they normally would have. So you're going to have a lot of small businesses that would just rather not give health care coverage. I have friends that are still giving coverage to their office. They have, the average doctor, one physician office, doesn't have a lot of employees. They'll have like 4 or 5 people. Some of them are downsizing. Some of them are just keeping 4 people. And some of them are just doing paperwork after hours, so they're paying them a little longer. But the issue is that a lot of people, because of the increase in premium, which already went into effect, and some of it is because of the pre-existing condition issue, they're just not going to give them health insurance, and they're just, not even health savings account.
But that starts at 10 employees. Where does that actually begin, where they are required?
Under 10, it says under 10. That was the benefit, but a lot of them have just opted not to even go there. They would just rather not offer it at all. Okay, so I suppose we should let Chet go and ask a question, huh?
This is important. Of course, you heard all kind of rumors during the last election about the death penalty. The way I understand it is, if you cannot show to this panel that you have something to offer in the future to society, you will not get operated on or whatever. Is that true?
Well, there is something on those panels here that I have. That I don't. Oh, the question was if there was no benefit, let's say after 70 because of whatever condition that you have, are they going to ration or deny your health care because of that? Let's say you have heart failure and your expected life expectancy because of the heart failure is 2 years. Are they going to say, well, knees actually live 10, 15 years of life, the prosthetic, you're going to be gone in 2 years, we're not going to offer it. I didn't really find anywhere anything that said that. I think that that's a lot of fear mongering, but here's what I do believe. I do believe that they are going to limit the amount of people that get those things by increasing the premiums. Because, and this is already happening in Canada where people, how they say, well, if it's a preventive service, you're gonna not have to pay a copay for it, and that's already happening. So some people that are gonna get a colonoscopy or a mammogram, there's no copay for that as long as it's for a prevention. If you have a lump, you have a copay. If you have blood in your stools, you have a copay on the colonoscopy. But if it's just for screening, you don't. But the problem is that is going to increase the number of people that are going to go get those procedures. And with increasing, that's going to slow down. So in other words, what would take 2 weeks to get done, it's going to take 4 or 5 months. And you guys see that now where I have people that come over and ask me, they have a relative that is a Canadian citizen. And I tell them, we don't see anybody that doesn't have the insurances that we take. So services are going to be delayed. Some services, the co-pays or your responsibility is going to be higher. So you say, well, I'm not gonna. It's like hearing aids. They're like $3,000. You're like, well, I'm not gonna get the hearing aids if I have to pay that much. So that's what's gonna happen. It's just that there's going to be a lot of more things, especially medical devices. When you look at a paper came out. There's a company in Sanford, Florida, that does medical devices. And they were, their profits was about 35% on the medical devices that they sold. Well, now they're going to be regulated where they can't make more than like 15 to 20%. Well, if you're going to go into a business where they don't allow you to make more than that, and then you will have to do something with the excess of that. You'll have to sort of, do a give back or give so much for charity. I don't know. But they are going to review that. If you make more than that for whatever reason, then they'll probably take a portion of that, or you'll get a super tax. And that's going to decrease the amount of people that, I mean, imagine if there's no incentive to provide better and better pacemakers and defibrillators. And a lot of people don't believe that. I looked into it and I said, that's kind of weird. But it really is. The other issue that I want to mention really quickly, there is something that they call outcomes-based measure. And basically that's the whole issue of over 75. And that just basically means that if this technology saves lives by a number of patients, then we're going to pay for it. Otherwise, we won't. Well, there's a lot of stuff that as doctors we do for patients, and the insurance companies cover it because they don't want to get sued for something. Plus, it does provide improved quality of life. The studies may not suggest it, but they do it. And, one of the issues is, well, if you're 85 years old, the risk of an aortic valve replacement is such, we are not going to cover it. So things like that are going to happen. Not for your common day things, but we are expecting that probably 10% of the services that we ask for patients now that will improve quality of life, not necessarily survival, are not going to get covered. Sure.
Those who want to ask a question, can you come in the middle and just form a line? I know the one lady's been standing quite a bit. If you've been standing or raise your hand, let the people go in front, okay? If you just raise your hand, and then we'll make it a little more. Okay? Is this beneficial? You guys like this? Yes. Okay, very good. If you would. Now, I know this young lady was, why don't you come on up front? She was standing there.
Hi.
What happens if he asks to see me?
Okay. I'm sorry, say that again. You have a daughter? In an accident. Okay.
She had a broken neck, she was paralyzed, and she had organs and back outside her life. And basically, we had a private payer insurance with Mega Life Health Mortgage.
Okay.
And we had major medical accidents, and it capped out at $1 million.
Correct.
So we had a doctor tell us that her broken neck was fixed because we didn't have any more money to pay for her surgery because we had capped our insurance. And then somebody came to us and said the doctor lied, her neck is still broken. And they would have left her as a cripple. Her neck was like this, the neck was not fixed.
So your question
And
is?
how would Obamacare help legal American citizens who live in this country when I saw a tremendous amount of illegal aliens in the trauma centers all across the country, and especially when we got our care packed full of Hispanic people, population coming from across the border, getting all these free services at the expense of my little girl being denied employment
So your question is?
survey. So how is Obamacare going to address a situation like that? Because what if we don't want to get government insurance and we have our private insurance and it caps out because of a major accident that somebody did to us? We were responsible people, middle-class family. How could you guys deny
All right, so
Obamacare going to help the middle-class families who want to keep their own insurance?
So let me try and summarize what she said. Basically, she was telling us that her daughter was involved in a catastrophic accident, and she had a lot of injuries, neck injuries, and some other very severe injuries. But then her annual benefit match was $1 million, and they did not want to provide more services because she had reached her $1 million benefit. But she sees other people come in here and get health care services for, other conditions, and some of them are not legal aliens.
And they're not serious either.
And a lot of them are not serious injuries. Well, the first issue there is, people that do not have insurance use the emergency room as their primary care. Why? Because they'll find some way, the hospital will find some way, or the social worker to make sure that that gets covered, or else the hospital doesn't get paid. So they'll apply for a special waiver, or they'll ask the patient to pay 20%, and then they'll get reimbursed 60% or whatever from Medicaid. So there's a lot of different things and loopholes that hospitals do to get that taken care of. Now, as far as the annual limit, here's the issue. There are plans that offer a limited annual benefit. For example, McDonald's, this is what is called a mini med plan. For example, somebody that has here a Medicare Advantage plan, let's say like Humana or WellCare or Freedom, Optimum, those plans, the beneficiaries of those plans have a maximum of $1.5 million a year, meaning that your calendar year, if you spend, if all your health care is $1.5 million or $2.5 million, I don't remember exactly, but your plan will tell you, then the plan will cover minus your deductible and your premium, okay? After that, then they don't. And some plans after that, you pay 10%. I've never seen anybody spend that much money. But there are a few conditions where that will happen. A lot of the times it's young people because of the cost of multiple surgeries that they can tolerate where older people can't, plus a lot of physical therapy and rehabilitation services. The other condition is organ transplants, heart and lung, bone marrow, things like that. So it does happen, it's just not a common occurrence. Well, they're putting a limit on the number of plans that have what we call mini-med, meaning that plans, like McDonald's that say, hey, I will give you health insurance, but your annual benefit is less. Those plans are going to go away, and with that, what's going to happen is only the other plans will remain that offer more, but the premium is going to go up. So the premium that you were spending is going to go up in 2014, so that they can either keep the million or raise the bar. The CMS and the health department said that they didn't want these plans to just all of a sudden drop these patients. But the problem is, this is where they did the waiver. If you guys remember the temporary waiver that they did the temporary waiver for the United Federation of Teachers Welfare Fund, 350,000 enrollees. So they had a waiver, which means that their benefits were not going to expire. And then they also did one for the District Council Health and Security Plan with 300,000. So a lot of unions receive these benefits, but they're going to expire after all the outcry. They're going to expire in 2014. So what's going to happen is the premiums that these people, when this expire, if they want to maintain that annual limit or that lifetime benefit, then the premiums are going to go up. So even on these people. So there's really not much.
Quality of care is going to go down in the free market by a lot, because our insurance didn't cover physical therapy, which left my daughter, by the way, permanently paralyzed. A 12-year-old girl is permanently paralyzed due to the fact that quality going down. We have.
There is nothing in the plan to protect you from that. It might actually end up dropping some. So nothing is going to protect you from that.
Thank you, I appreciate it. And we have the next question, because, folks, we're going to stop this at 5 after 8. I know it's very interesting. So for those in line, if, we've got about 12 more minutes, okay? Ms. Barr,
Yes.
you have a question?
Yes, doctor.
God bless you, by the way.
Are you familiar with the Medicare payment advisory board? It's sort of what is the concept of this bill, and does it have anything to do with death?
Well, the death panels. Okay, she wants to know about the advisory board that is going to regulate payments for healthcare services. And you, sooner or later, they'll find something. So a lot of doctors are just not going to ask. Now, the issue, they're just going to keep whatever they get. But the issue of the death panels, what they will do is they will provide counseling for end of life. And that is what has a lot of people bent out of shape, because it really depends, on how the government wants to adapt that. For us right now, counseling for end of life means that we will tell you, based on the condition that you have, what do we think is the best for you, how can we make your life comfortable, but you have the option, and you can say, oh, I don't care, I want that done. Right now, if you have a breathing problem and you're in the hospital and you want to go on a ventilator, if the doctor tells you, well, this is your risk, and you say, no, I want to go on, you will. there might be some things down the road where it's going to be harder for you to get end-of-life treatment. Palliative care, it'll be tougher for, let's say, hospitals to say, under this condition, we're gonna go ahead and try the end-of-life care. So it's gonna be really hard. Doctors don't generally like doing that, but when there are no resources, there are no resources. And you just have to tell the patient, there's no resources, we can't cover that. That's where the issue with the chemotherapy comes into. It's going to be very hard for us to get some services approved for patients. We're going to have to jump through a lot of loopholes. And, a lot of that with Medicare, you can't question that. It's what they say. Health insurance plan, they're afraid of getting sued and all that because they stand to make a profit on the premium and on the beneficiaries. The government doesn't. And an example of that is the VA. I have patients that go to the VA and they come to us to get other things done because when the VA says no, it's no matter what. So that's an example of government-run healthcare. But the biggest issue really is, it depends on what side of the aisle you are. If you believe that, private insurance companies and free enterprise for individuals to make their own decision is the best for the country, then you're not going to like this bill. That's just the truth. If you like capitalism and you like freedom of choice, then this bill is not for you. But if you want to rely on the government to make decisions for you or to look out for you, and you know what? I have physician friends that believe that this plan is good. I believe the plan has some good things and some bad things. But most of them are bad. And they did it without the input of physicians who are going to be, facing people, with these issues. And I think we should just pilot it, meaning we should just done it in one place slowly and then move it to other places, which is what we do as doctors every time we try something. We don't just say, hey, let's give everybody this pill, because we knock out 1/3 of the population. Then healthcare costs would really drop. That's not how we want it. But, that's how I think they should have done it. But if you believe that you don't trust, capitalism, and you don't, health insurance companies are greedy and all that, and, that you rely on the government to make these decisions appropriately, then, this plan is for you, generally speaking.
Thank you. Go ahead.
My question is, I just lost my husband in December, but he was a cardiac and renal patient for a long time. It was like a juggling out, trying to keep him qualified under one, Medicaid or Medicare, whichever it is, because the private insurance is, it runs way too high, and then if I have to take care of him at home, then, it's like, I can't concentrate on my career. But it came to a point where we have to practically be indigent to keep him on Medicaid. Now, when he became a renal patient in the last 2 years of his life, his early Medicare kicked in. Mm-hmm. And we thought, okay, maybe your Medicare will kick in and we won't have to worry about qualifying you under Medicaid anymore. But then it turned out that the law allowed Medicare providers to pursue the 20% that Medicare would not provide. Now, I had read somewhere that Obamacare, once it kicks in, it will remove the 20% that Medicare is allowed to, Medicare providers are allowed to pursue from the patients. Is this true? Because it will make a big difference.
Okay, thank you very much. You got your
question? I'm not saying that it's not there. I haven't read anything about that. I will tell you this, end-stage renal disease, which is when you're on dialysis, end-stage kidney disease or renal disease is when you're on dialysis, is a special denomination. Basically what happens is that at that point in time, Medicare will cover whatever age you're at. So if your kidneys fail entirely at 50, then you will be eligible for Medicare. But there are some things, your dialysis care is going to be covered. But there are certain fees. So there are some things that the kidney doctor, for example, and the problem is a lot of doctors don't know this. But there are some things that your kidney doctor will do that the government doesn't consider, care for end-stage kidney disease. So you will have to pay for that
This is true.
unless you have Medicaid. And an example is,
This is why we have to keep it qualified under Medicaid.
there's too many rules. And it's hard for doctors to keep track of all of them. Well-intended, well-meaning doctors, and a lot of the kidney doctors have been around for a while know it, but they keep changing them as well. And I tell you that because it happens to me. I have about 6 patients on dialysis, and the problem is that, I send them somewhere, and the services for us are covered, but I send them somewhere, and they may do some sort of test or something that is not covered for end-stage renal disease, so it's not covered for their qualification, and then they get a bill in the mail. So that is an issue. That is an issue.
Okay, very good. Thank you very much. We appreciate that. Folks, right now it's 8 o'clock. Actually, it's 8:01. We're going to have 4 more minutes and then we're going to get on with the program. Okay, Joe?
From your perspective as a physician, what are some things we can do as a party to help minimize the negative effects of Obamacare?
The negative.
Wait a second. You notice how short that question was?
Very short. Well, his question is, how can we minimize the impact that the legislation or the negative effects? Well, just like everything else, very important for you to stay informed of what the benefits are. Second, really, the most important thing is find a way to get insurance to private companies, private companies while they still exist. In other words, work. Which Republicans like to do, and I don't mean that to be facetious, but you have to, you're going to get creative because the health savings plans are going to disappear. And just to give you an example, health savings plans would allow you to buy over-the-counter medicine. Now, they're not going to allow you unless the physician writes a prescription. So now, you're going to have to go to the doctor for something that you didn't have to before. So the key is, go to places like the Heritage Foundation. Go to places, that are reputable, like, for example, the Department for Health and Human Services. They'll give you a lot of information. There are websites, and you can Google these that, you can just type in pros and cons of, the patient portability, accountability, or Obamacare. And they'll tell you, pros and cons. You look at different websites, and they'll tell you, and then there's a section that tells you if you are an employer, if you are an employee, if you are, if you self-insure. So there's a lot of websites out there. Just like everything, whenever you have a condition, a medical condition, that you don't really understand and the doctor wasn't good at explaining, you have to research it. The same way when, you have something that you own that you want to know how to protect it, you do research. The same thing with this. Do as much research as you can and then ask your elected official and see if they have somebody that can give them information. But being well informed is the best way.
Thank you, Joe. Good question. Ms. Barber.
There's one other provider that has been dictated how much income that they can make, and that's the insurance companies. As you
Yes.
probably know, the 85% loss ratio.
80 to 85,
Yeah,
yes.
so just want to bring that up. And to piggyback on Joe's comment, just today, the Florida Select Senate Committee met today about the implementation of the healthcare exchanges in Florida.
Mhm.
And we have, I think, 27 states, I believe, that have now rejected the implementation of healthcare exchanges. I wonder, I know a lot of our friends have been contacting those members of the Senate Committee and encouraging them to turn down the waiver. And I'm just wondering what your opinion is of implementation of healthcare exchange in Florida.
Well, first, what you talked about, the 80 to 85%, that's the medical loss ratio. That means that the insurance companies are supposed to have a medical loss, meaning if your premium is, let's say, $500, they're not supposed to make more than $100 on it, or 20%. Well, here's the problem. The minute you start saying you can't, sort of like the electronic devices, the minute you start saying, well, this is a business where you can't, no matter how well you do, you can't make more than 20%. If you do, you're gonna have to give it back or find some way next year to give it to the beneficiary. So that is gonna limit the number of people that want to start an insurance company. So that's gonna decrease your options. And when you do that, and a lot of insurances have actually dropped already just because it's hard for them, because if they run an efficient plan, they're always gonna have that benefit. So it's gonna be very hard. They're gonna have to either drop premiums or something. And when you own an insurance company, you have shareholders. When you have shareholders, you can't make $7 a share every year. They're gonna dump you. You have to make $7.50 and then $7.60. So you always have to have some improvement. As far as the insurance exchanges, it's not supposed to kick in until 2014. There are some benefits that come with it from what I understand. I really haven't looked a lot into the health exchanges, but I think that eventually, and this is my feeling, eventually I think Florida is going to have to adopt it and accept it. Because there's gonna be a lot of benefits to it, and they're gonna tie some other healthcare dollars that we get.
But they're shooting it back up to the feds, because they're not really set up to do it, so that's the strategy, is to.
And they have funds for
reject
that.
it.
They have funds for that, so they are gonna distribute the funds, but the funds are not gonna be enough, so what happens is they're gonna give you the money to start it, the money is not gonna be enough, and then you're gonna have to use some of the state money.
Ladies and gentlemen, this will be the last question. This will be the last question, so I apologize, folks. We do have other parts of the meeting we gotta get to, okay? Would you like to ask your question?
Do you have to have an income to qualify for Obamacare?
Do you have to have an income?
Yeah.
Meaning they're doing, people that are not currently insured or cannot afford an insurance will be eligible for Obamacare, as you guys call it. So if for whatever reason, you can't pay a premium or your employer doesn't offer it, you will, depending on how much you make, if you make $100,000, they're not going to give it to you. So you'll have to probably find, an insurance. So you can't just say, hey, I'm gonna elect not to buy insurance for myself and go into the government-run healthcare. You can't do that. But what will happen is you have, employers that don't offer it to their employees. So if somebody is making, $11, $12 an hour, if they're not getting it from their employer, then, they will be eligible to go into the government-run healthcare. But the bigger issue, though, bigger than that, is eventually what will happen is the regulations are going to be such, because the president said, everybody remembers, if you like your doctor, you're not going to lose it. If you like your insurance, you're not going to lose it. If plans are going to be grandfathered in, plans are not going to be grandfathered in. There were already about 40% of plans that were supposed to be grandfathered in that had dropped. And then there was something here, and I want to end with this, so I'm glad she asked that question, where it talks about the grandfathering in the plans. So bear with me for a second, because I want to make sure that I'm accurate on this. Okay, so health insurance plans, I'm quoting this, by the way. Health insurance plans cannot be grandfathered unless they meet a variety of requirements. Furthermore, HHS regulations indicate that plans can lose their grandfather status for modifications that are not deemed reasonable changes routinely made. So if they made too much of the premium, or they raised it because they have sicker enrollees, then those plans are going to lose their, or stand to lose their grandfather status. The other issue is if they have changes to the annual lifetime benefit, that $1.5 million that we mentioned earlier. So here's the issue. PricewaterhouseCoopers surveyed employers. 51% of them said that they didn't maintain their grandfather status, so they had to drop the plan. So the other issue is, former HHS Deputy Assistant Secretary for Planning and Evaluation, John Hoff, wrote that, quote, the administration can decide on an ad hoc basis and without standards which changes a plan can make and still remain grandfathered.
That's wonderful.
So it's not going to happen. It's not. So this is going to lead us all down to a path where, more and more people are going to be enrolled in the government's plan, and the care is going to really pretty much be dictated by the government. So there's going to be very few insurance plans, I would say probably 10 years from now. Very few.
Sort of like the VA.
We'll be little by little, people on a Medicare Advantage plan, there's gonna be 50% less people in 2020 than what there are now. So all those people are gonna be in those exchanges. Absolutely. Yeah, we're gonna become a global VA.
Ladies and gentlemen, Madam Chair. Is that official? You want something?